think we're going to go ahead and get started. Thank you for your patience. I think if I knew this was televised, I would have fixed my hair a little bit more. That's okay. Hi everyone, my name is Karen Osilla. I'm a clinical psychologist by training, and I'm also a researcher at the RAND Corporation, where we were responsible for evaluating on a statewide level prevention and early intervention trainings across the higher education system. And so my job today is to tell you some preliminary results related to that evaluation. And I'm also very pleased that Negar Shekarabi is also here with us. She is a senior psychologist at the UC Irvine. I can tell you a little bit about the numbers, but she's going to really share about the on-the-ground experience delivering and implementing and evaluating these trainings at UC Irvine. So we're going to share the time today. And it's a round tables, and it's a small group, so I'm thrilled that we can probably exchange a lot of great ideas together, collaborate. If you guys don't mind, would you just say your name and tell us where you're from? Because it's a roundtable format, the first time we did it around, it was a really nice conversation. I learned a lot from the audience. We were able to exchange ideas. So would you mind starting, please?
Sure. Jennifer Carey, and I'm from Golden Gate University in San Francisco.
Great, thanks.
Evan Sternard, counselor at Captain Hills College in Yucaipa, and I'll bet nobody knows what it is, but it's near San Bernardino.
Excellent, thanks.
I'm Jacqueline Moreno. I'm from UC Riverside.
Good.
I'm Sandy Lyons Rowe. I'm from Santa Monica College.
Oh, good, just down the road.
My name is Kelly, and I'm from Maloney College.
Where is that at?
It's in Fremont, which is in Northern California, like the East Bay.
Excellent, thanks.
I'm Shelley Welty. I'm from Pepperdine University.
Thanks, Shelley.
I'm Jean Erlenborn from Santa Rosa Junior College.
Thank you.
Marge Razor from Miracosta College. It's a community college in Oceanside.
Jackie Curta from UC Santa Barbara.
Edwin Feliciano from UC Santa Barbara.
Great, thank you.
Michael Jocelyn, I'm the Dean of Students at College of Canyons and the chair of our behavioral intervention.
Great, thanks.
I'm Larry Charlotte from College of Canyon.
Susan Bell from UC Berkeley.
And I'm Kevin Thomas from Claremont University in Social.
Great. So we have a range of geographical areas represented in campuses. So my hope is that in addition to talking about some of the slides that we present today, that it'll be a nice exchange between you guys in terms of sustainability and trainings and what's been helpful for you. So my goal is to talk a little bit about the Student Mental Health Prevention and Early Intervention Training Initiative, talk about what RAND was tasked to doing in terms of doing our statewide training evaluation, describe some preliminary results related to two main outcomes. One is the reach and penetration of these training events that that you guys all administered, and then some outcomes related to what training participants felt in terms of their self-efficacy and their behavioral intentions. And then also throughout the discussion, as well as in Negar's presentation, have a discussion with you about sustainability of training events and evaluation. So as you guys know, across the higher ed system, you are tasked with prevention and early intervention training for your faculty, staff, and students. And this included a lot of different types of trainings, including standardized trainings, just like mental health first aid, suicide prevention assist and QPR, as well as other types of trainings that helped students, faculty, and staff recognize signs of distress and intervene accordingly. In addition, the systems had some online resources. So here's an example of CCC's website where they offered some ideas of where to get more training and technical assistance and how to access Cognito. The CSU website that had each website and each campus and how you can get more information about certified trainers in your area. And UC's red folder that helped faculty and staff identify the signs of distress and where to go after they did that. So at RAND, our idea or our evaluation purpose was to assess first the training and reach and penetration of all these trainings. So you guys were doing all these trainings, but who did they reach and whether or not they reached diverse populations? And the second thing we wanted to look at were, of the participants that attended these trainings, how did they feel the training was helpful? What was the quality of the trainings, and then whether or not they benefited in terms of their confidence to intervene or refer students with mental health distress issues, and their likelihood to intervene or refer students with mental health issues. I should say from the outset that our evaluation is just a subset of trainings that were administered. As you'll see in our numbers later, you might sense right away that it's only a fraction of the trainings that the system's administered, and that's because of our sampling strategy, which I'll describe in a moment, and also because it's limited to the number of people that actually completed survey data. That's the data that we have that we could tell from. So our sampling plan was in collaboration with UC, CSU, and CCC. We worked with representatives from each of the higher ed systems to figure out a feasible and a realistic sampling strategy where trainers would not feel overburdened, that they would feel encouraged and motivated to get their participants to complete the survey, and that it was collaborative on both ends. So with UC, we developed a sampling plan with their representative to assess approximately 6 student and 2 to 3 staff faculty trainings per semester. We focused on standardized trainings, so those were mental health first aid, QPR, assist, reg folder. For CSU, we focused on all standardized trainings. And then for CCC, we focused on the 30 campuses that were awarded campus-based grants. So all the trainings administered at those 30 campuses. To measure training, reach, and penetration, we asked trainers from the subset that we sampled to give us information, to give brand information on the campus that they delivered the training in, date, topic, and total number of people that attended. And then we asked them to provide surveys based on training participants, and we had student and staff surveys, which were basically the same survey, but little wording differences here and there where it was appropriate. And to enhance the feasibility of completing the survey, we created 3 different survey administrations. So we first started with paper. We had them do paper surveys, and we found out right away that not a lot of people like paper nowadays. We weren't getting a huge response rate. And so instead, we also in addition to paper, implemented internet surveys. So people could go to our URL, our website, and complete the survey online. Some campuses had really innovative strategies to do that. They would hold trainings in computer labs, and 5 minutes before the end of the training, they would have the participant go ahead and log on to the training, which is right in front of them. Trainings were also with students, and so a lot of students have mobile phones. So what we did was we also implemented a mobile survey where students could text a certain number to a phone number and get the URL on their mobile phone, and that way they could do it on their phone right away. We also had 2 different types of surveys. So we had the traditional pre and post, where a participant would answer our survey before the training started, and then at the end of the training, they would complete another survey after that. So that's our traditional pre and post. But we quickly learned that some campuses had like 1-hour trainings, and so it would kind of limit the amount of time that participants could go through that training. And so we created a retrospective version, which is administered once. So at the end of the training, participants were asked these questions: before I attended this training, how much do you agree with each of the following statements? Now think about after attending the training, how much or how little do you agree with each of these responses? And so that kind of helped with the burden in terms of the training participant. So we had a traditional pre and post, and then we had a retrospective version. And the research shows that the retrospective method is as valid as the traditional pre and post. It was really important to us that we support the trainers as much as possible, so we gave them kind of step-by-step guides. Negar is going to show like a slide that we helped develop that helped them to explain how to complete the survey, the different modes, for example. We also gave scripts to trainers, a little paragraph that they could say at the end of the training to describe the survey. We also made sure that the trainers knew that the survey was completely anonymous, and so that they should emphasize that to their participants, so that participants wouldn't worry about their trainers finding out their responses. We also emphasized that it was a 5-minute survey and it was voluntary, but very helpful for the evaluation. All of our procedures were approved by our IRB, and certain campuses also needed specific campus-level IRB, and we helped with that as well. So here is our first outcome from the pre-post survey. The first outcome that we looked at was confidence to intervene or refer students with mental health distress issues. And so those questions ranged from a 1 to 5 point scale, from strongly disagree to strongly agree. And it was broken down into confidence to intervene. So things like, I feel comfortable discussing mental health issues, I am confident in my ability to help, I am aware of the warning signs. And it also broke down into confidence to refer. I can identify the places or people, and I have easy access to education or resource materials. We developed these two constructs, confidence to intervene and confidence to refer, by adapting from suicide gatekeeper surveys. So these are not new items. These are surveys that are validated in the field that have been used with suicide prevention trainings. And we also did a factor analysis to statistically look at the clumps of questions that group together under confidence to intervene and refer. We did the same with likelihood to intervene and refer. So this ranged from a 1 to 4 point scale, from very unlikely to very likely. Likelihood to intervene, some examples would be asking him or her specific questions to assess their level of distress, encouraging him to get professional help. Likelihood to refer, talking with parents, giving him a specific phone number, calling a security administrator or counsel to support the student. So those were the two main outcomes, confidence and likelihood. We wanted to assess how many, what was the reach and penetration of these trainings. And so we evaluated the corresponding number of trainings by higher ed system, so 99 UC, 234 CSU, and CCC 93. This, again, is a subset of the trainings that everyone delivered. It's a subset of trainings that we have data for and were within our sample. Of the students and staff that completed our surveys, we have more students than staff that completed the surveys, and that kind of made sense to us because more students and staff were targeted in these trainings. So for UC, for example, it's a little inverse. So 398 students versus 430 staff. At Cal State, there were more students and staff. Same with CCC. The percent of female is higher than the percent of male in this slide. So for those of you guys looking at these stats, how does that compare to kind of what you know on your campus? Anything surprise you? Anything jump out at you?
Well, I know in classrooms, it's usually pretty much even. So females complete the surveys more than males.
Maybe, yeah. Females might be more willing to complete the surveys than males. How about the student-staff ratio? How does that compare with what your experiences were?
I wasn't particularly involved in this in my area of work at the university. That surprises me that the UC number of staff is higher than the number of students. Do they have is there a reason why? Or have the CAPS organizations involved explain perhaps how that might occur?
Yeah, I don't know. Negar, do you have any thoughts about that?
I mean, I know on our campus, we focus on faculty and staff a lot for these evaluations, but we're just one campus. But
I've heard that sometimes it's more difficult to, and Negar's going to talk about, to engage faculty, and so a lot of times their efforts are focused on recruiting them for trainings. So that might be one reason why. The next thing we wanted to do was look across systems. So across all the higher ed system, what was the reach and penetration? We found that across systems, the training participants that completed our survey were about 70% male, quite diverse, about 40% white, 36% Latino, 13% Asian, 6% Black, and 8% other. We also looked at role, and we wanted to look at, of the training participants that filled out the survey, what was their role. Largely student, 73%, about equal staff, equal part-time faculty, about 8%, 6% administrator, other health professionals and mental health professionals like counselors and nurses. Any reactions to this slide in terms of what you had expected or know in your campus?
I'm actually surprised that the faculty
So you would have anticipated more staff versus faculty. Good. Any other comments?
Well, the other slide, there's just such a preponderance of female students being reached over males. That's just something that I think, gosh, we have to get to work on that.
Yeah.
Got to.
Yeah. Yeah. You know, certainly it could be a factor of survey completion, but 70% is a big number, isn't it? So it'd be interesting to compare it with, you know, your guys' experience. It sounds like some of you guys have an equal balance of men and women, but it'd be interesting to look at this further. Okay, so what we wanted to do next is we wanted to look at survey responses. We wanted to look at the two outcomes, confidence and likelihood. So our first outcome, confidence to intervene and confidence to refer. So the green bar represents their values before the training. The yellow bar represents their value after the training. The farther to the right you are, the more strongly agree, the more that you feel you are confident after the training. So we find across the systems that there's an increased confidence to intervene and increased ratings to refer as well. So overall, we find that from pre to post that people feel more confident to intervene and confident to refer. It's a great finding. We also wanted to look at whether subgroups different. We wanted to see whether outcomes differed by system. We also wanted to see whether or not outcomes differed by ethnicity and role. So those are the three covariates I'm going to look at next. For system, we found no difference. So CCC, UC, and CSU all had similar improvements before and after the training regarding confidence to intervene and refer. This is a table with ethnicity and role. So ethnicity and role, the positive values indicate more improvements. The negative values indicate fewer improvements. And for ethnicity, the reference group, our stats program designated it as white participants. Then for role, the reference group is administrators. So what I would do is only look at the yellow bars, because the yellow bars relate to statistical significance. So when we look at Latinos compared to white participants, Latino participants reported greater improvements in their confidence to intervene and refer. For role, students and faculty reported greater confidence to refer out compared to administrators. Health professionals and mental health professionals reported fewer improvements to intervene and refer compared to administrators. So, you know, we just crunched the numbers, but we're not on the ground. So I'm very curious what you guys think of some of these findings and how that matches with what you see on your campus. Any comments about any of the findings related to ethnicity or even role?
Well, mental health certainly jumps out to me.
Yeah.
I would be very interested to look at that further as to some of the causality of that.
Yeah.
Like what goes into that highly disparate number versus the others.
Yeah, why do you guys think there were fewer improvements for health professionals?
Because they have background
Yeah.
already.
Yeah.
So they went through the training, but it didn't necessarily increase their
Right.
knowledge at all.
Right, they're clinicians by background, so they're likely coming in with high confidence to intervene and refer, and so having a change probably is harder to detect. Very good. It's nice to see the changes in terms of student and faculty, because I think that's the target of a lot of the trainings that the campuses did. Thoughts about the finding regarding Latino participants versus white participants? Any insights into that?
Culturally, they might be more likely to intervene or refer, but not if they have information, they're more likely to act on it.
So maybe culturally there might have been some barriers to intervene or refer, and after the training they feel more confident? Is that what you said?
No, actually I said, so culturally they might be more likely versus other ethnic groups to be willing to engage, and now they have the information, so their numbers might go up more.
They feel more equipped afterwards.
Yeah.
Okay, got it. Good. Good. So yeah, these are just preliminary results. It's kind of an interesting group comparison that we found. So we'll have to monitor these. So our second outcome was looking at intentions. So the likelihood to intervene and likelihood to refer. Overall, these, we had significant improvements post-training as well. They were, in terms of measuring confidence versus likelihood, we had more confidence ratings versus likelihood, as you might expect, that people feel more confident, but when it comes to actually doing it, they feel a little, their scores were a tiny bit lower. But across the systems, we find improvements in terms of their likelihood to intervene and refer. Again, we find no differences across the systems, so UC, CCC, and CSU had similar improvements. We looked at subgroups again, and we found, compared to white participants, Asian American participants had reduced fewer improvements in the training compared to whites. And then when we look at role, we find that faculty had increased improvements compared to administrators. Thoughts about this slide or any comments about this? The faculty included part-time and full-time, so it was interesting to see that finding as well, especially with the barriers for faculty attending the training. Okay, I'm going to keep on going then. So, you know, there are some limitations, of course, to this training evaluation. One, we did not evaluate all of the PEI trainings that were available. We only evaluated a subset, and the subset that we have data for. We have no comparison group, so we don't know whether or not these changes were above and beyond something that someone would normally get if they didn't attend the training. And there might be some self-report social desirability here. You know, after the training, people are really motivated, they're excited, you know, they want to show that, you know, that this was really helpful and worth their time, and so that's always a limitation to our data, because it was self-report. But we had a large sample, I'm not sure if I mentioned it, but about 6,000 participants completed our survey, so it was a big chunk of people. We also had consistency in administration. We really focused on technical assistance, making sure the trainers knew how to administer, what script they should say, and what points they should emphasize regarding anonymity. And hopefully that process encouraged honest feedback on the participant side. So our conclusions are that the trainings reached a diverse audience, mostly students, but that overall we find improvements in their confidence and likelihood to intervene and refer. There's slightly greater increases in confidence, as you might expect. We also found some group differences that we're going to continue to monitor and see what happens in terms of self-efficacy as well as behavioral change, behavioral intentions. There are a lot of people on this team that are not here that I want to acknowledge for all of their hard work. There are also resources on our website that if you want to monitor some of the reports that come out. This training was just a small component of our evaluation. We also have a large system-wide student, staff, and faculty survey that we're administering online that's supposed to be representative of each campus as well as across higher ed. And that website also has information on some of the other initiatives, including suicide prevention and stigma and discrimination reduction. So we're going to shift to Negar. Negar, again, is a psychologist at UC Irvine, and she's going to share a little bit more about the on-the-ground experience of providing these trainings at UC Irvine.
So I'm going to start by talking a little bit about a workshop series that we host at the Counseling Center that we've had consistently hosted at least once a quarter since the fall of 2012. But when we were via the grant given the opportunity to do these evaluations, we chose the workshop series as one of the ways one of the sets of trainings we were going to evaluate. Also, for folks who are not as familiar with our campus, UC Irvine, we have close to 30,000 students. And we have approximately 2,000 faculty and 4,000 staff. So our workshop series that we host via the Counseling Center is a 3-part workshop series, and it includes key trainings that the Counseling Center offers, but that also relate really well with the Cal Mesa grant deliverables that we were asked to implement on our campus, so suicide prevention and stigma reduction. And faculty staff training are all encompassed in these 3 workshops that I'll describe in a little bit more detail. Most of the trainings I mentioned are facilitated by Counseling Center staff with the exception of one, which I'll describe. The workshops would take place at least 1 time a quarter, and we made registration for the workshops available through 2 different platforms. So at UC Irvine, there are 2 ways that faculty and staff can sign up for additional trainings. One is through the HR website, and one is through a portal called EE. What we were told consistently is that staff do not do much on EE, and faculty are not on the HR website much. And so if we wanted to capture both of them, we needed to have registration available on both platforms, so we made that possible. We would facilitate the workshops on 3 different days during the same week, or the same day of 3 consecutive weeks. We would kind of spread them out in different ways, typically during the lunch hour for convenience. We marketed these workshops both passively and actively, so we would do email blasts to the entire campus. We would send out smaller email blasts to departments or clusters, but we also did some more active marketing to specific departments on campus that we wanted to connect with, or that we already had somewhat of a relationship with and kind of had a foot in the door already. Myself and another staff psychologist who worked on the grant with me essentially spent some time with at least 6 different departments, going department to department, meeting with the deans, talking to them about the workshop series and some other services that we have that were grant funded, and sort of like as a package, here's all the things that we can offer your department, and got them on board to either allow us to host the training in their department physically, or partner with us to host it elsewhere on campus, but at the very least to market it heavily, or encourage their faculty in particular heavily to attend. The workshops could also be requested as needed and tailored, so we would offer them always consistently once a quarter somewhere on campus and market it, but also we would often get calls or requests to do 1, 2, or all of the workshops specifically for a smaller group tailored for them, and we would respond to those requests as well. This is just a sort of a snapshot of the inside of the brochure that describes all the trainings and tells them all the ways that they can sign up and all that kind of information. The first workshop, so going back, this first workshop number 1, dealing with disruptive and distressed students. It's a 60-minute workshop, and it's essentially an introduction to our behavioral intervention team that we have on our campus. We call it the campus consultation team at UC Irvine. So during this 1-hour training, they will meet all the core members of the campus consultation team. So you can imagine a lot of coordination goes into getting the director of the counseling center and the chief of police and dean of students all in one room to do a 1-hour training several times, but we've been able to make it happen. And so via this training, participants get introduction to the team, how they function on campus, what their role is, what types of cases and situations would be appropriate to bring to their attention, and also some more information about how to recognize signs of distress and when you might know that you are dealing with a situation where you might want to consult with the campus consultation team, and then how to go about doing that. This is the training that we tied very closely to the Red Folder initiative of our grant. So sometimes we would even refer to this training as the Red Folder training. This would be the training that everyone in participation would get a copy of the Red Folder, and they would be walked through it and all the resources on that Red Folder and how to access that information. At a later point, we also developed a smartphone app of the Red Folder, so we would also share that with the participants in this training. And so that's the first training. The second training in the series is our QPR Suicide Prevention Gatekeeper training. We did the 60-minute version of QPR. We modified it down a bit. When we would try for longer 90-minute trainings, we had a really hard time getting folks to stay for that long, so we kept it at 60 minutes. I just have a summary here for folks who are less familiar with QPR about some of the basic sort of key highlights of training that get transmitted through QPR. So early recognition of signs of suicide warning signs, of learning how to ask that question and engage in a conversation about thoughts of suicide, early intervention and referral, so getting them educated and connected more with the resources on campus, and early professional assessment and treatment. The Counseling Center staff, we are close to 30 at our staff. 11 of us prior to this rollout were trained to be QPR trainers. For you folks that know, that was a pretty hefty financial investment that we made as a center that the grant helped support us to do. It costs approximately $400 a person to get trained to be a QPR trainer. And then every 3 years, all 11 of us would have to get recertified for $60 each. So that was a financial aspect of that we invested in the training. But all of our QPR trainings are done by the counseling center staff.
So forgive me for perhaps not knowing the details on our campus since I'm not part of the campus, but were all of the campuses doing much of the same in terms of instituting the red folder and the QPR training? Did everybody kind of follow similar?
The red folder, yes, all 10 campuses had a red folder or a version of a red folder. Some campuses it's a different color, but it's still a red folder.
Okay.
I think Berkeley has a different color. As far as doing a suicide prevention training, yes, all 10 campuses are doing one, but not everyone's doing QPR.
Okay.
Some campuses are doing assist and mental health first aid, so we have different versions on our campuses.
So when the assessments were done, you were comparing like to like, I would imagine, in terms of training for training, or was it?
We actually merged all the data, so it's across the trainings.
And then the last training was our Step Up UCI Bystander Intervention training. This is a pro-social bystander intervention program. It's sort of one of those trainings that is really student-focused, teaching them how to recognize when something's happening in their campus community, and then to encourage them to intervene, step up, say something, do something. This Step Up was developed at the University of Arizona. It's nationally recognized. Our campus adopted it and rolled it out on our campus in 2012. As I mentioned, it's very student-focused. We modified it a great deal. First of all, we took a 3-hour training and we made it an hour and a half. Here we can get away with not adding that extra 30 minutes for Step Up. We also, if you're familiar at all with Step Up, it presents a lot of scenarios, video content, examples, and we modified and tweaked those to fit for the experience of faculty and staff. And shortened it, and we've gotten actually a lot of great, it's actually a really fun training to go through, it's different, and so we've got a lot of positive response from that. Also, our Step Up initiative on our campus, we have an advisory committee that's campus-wide. It includes representation from the counseling center, but also our health education office and Greek life and athletics, and we have a lot of representation on this committee who are all responsible for spearheading the rolling out of Step Up on our campus. So in this case, all of the counseling center staff is trained for Step Up, but there's also 50 other staff on our campus who can train Step Up, who respond to the requests as well. So it's really a campus-wide effort. The counseling center primarily handles the faculty staff trainings, and the other folks on our campus will do more of the student trainings with athletics and housing and peer groups. So there are lots of different ways I mentioned that we sort of worked our way through departments and sort of got the word out about our training so that we could get our numbers up and get these evaluations in. But I want to just talk about one scenario that sort of played out that worked pretty well. And we're really thinking about, we were keeping our top-down sort of approach in mind when we were thinking about engaging faculty a lot better. We were noticing consistently 99% of our attendees at these workshop series were staff, and 1%, if any, were faculty. So really early on, we recognized that we are not quite engaging them the way we would hope to be engaging them, and that really became a big overarching mission of how can we sort of figure out what's missing here and what we need to start doing differently. So I'm going to talk sort of more about this top portion, the academic affairs portion, and how we were able to a little bit kind of get in there over the course of the grant. So early on, when we were hosting one of the workshop series, the Faculty Relations and Development Director, who on our campus would be classified as a staff person, happened to attend on her own the workshop series for her own professional development. By attending the workshop series, she was connected to myself and my director, who serve on a campus-wide mental health initiative committee, and she joined the committee. And so that continued our collaboration with her. During the time that she spent on the committee, she identified that there is a great need for an overarching training on mental health issues for faculty, which was something we had recognized, but we were not faculty ourselves, so we didn't know how to get in there. And so with her work on the committee in collaboration with us, she was able to connect us with the executive vice chancellor and the vice provost about getting sort of their blessing to do sort of a mandatory all department chairs training at some point in the near future. And they actually did give sort of a top-down directive that there would be a mandatory training of all academic chairs in the spring of 2013, that we were allowed then to design and host for them, the Counseling Center. We were able then to do a two-part, a sort of truncated version of our workshop series, a two-part workshop series with approximately 75 chairs in spring, where they got the full QPR training and the campus consultation team training, and we had to drop the step up because it was too much to ask, I think. So we were really, for the first time since we started the workshop series, able to get in front of that many faculty. These department chairs then are essentially managing all of the faculty in their departments, and then we were able from that to generate more requests for workshops. It also created an ongoing collaborative relationship with Counseling Center and academic personnel. We consult with them often now on their trainings. We've come out to them to do other types of training, so it created this ongoing relationship. And also it allowed for some discussions around a need for mental health services provision on campus for faculty themselves. So one thing that got identified pretty early on is faculty themselves, when they're distressed, don't have someone physically to go to on campus to talk to. It's sort of a missing piece of the puzzle, and through this collaboration, they've been able to get approval to create a new position on campus for a full-time psychologist that would be there just to serve faculty and staff. That's in the works. So it was a really successful collaboration. Also, we were able then, via all of this work, to get our surveys out to a lot of these chairs and to the other faculty who came to our workshop series as a result of this collaborative relationship. So I wanted to say a little bit about how we integrated the evaluation process into these chairs trainings, but also into the workshop series when we typically present it. We really integrated the evaluation process into the actual training. So it wasn't always myself who was doing this training. It could be any one of our other 30 staff who were trained, but we sort of standardized the PowerPoints that went along with these trainings so that the last slide was this slide here, reminding the facilitator that they need to discuss evaluation before they let everyone leave. Also, in addition to having the slide up, telling them the various ways that they can complete the evaluation, we created small business card sizes, cards of this exact same slide, and we had it on every chair. So that if they didn't want to, or they didn't have the time right then to text UC to 24587 or punch in that URL code on their phone, they could take the card back with them to their office and do it later. Also, my colleague reminded me what I forgot to say earlier in the day is that then one of my colleagues took the role of, via the registration sign-in sheet, of sending everyone an email a week later and reminding them to do the evaluation. One thing we learned, we did suicide prevention training, so this came in really handy, that was related to clinical work, and we learned that they've done some research that if you give clients a full sheet of paper, they're going to throw it away, like a list or a to-do list, but if you give them an index card, they'll keep it. And so we kind of implemented that idea here of not giving big handouts of things, but little cards, and it seemed to work well here. So for us, now that our grant period is coming to an end and the money is gone with it, we have to really start thinking about creative ways to sustain a lot of the things that we've established. We've definitely integrated this workshop series into our vision of outreach at the Counseling Center. So what we've really incorporated is the things that this workshop series allowed us to do. Stigma reduction, suicide prevention, faculty staff training is a permanent part of how we're going to approach outreach. The variable part of it is the financial sustainability of the workshop series. There's a cost element. We've been able to get around some of it in some ways. The biggest cost is really space on campus, and hosting workshops on campus costs a lot. We've been pretty successful with some departments when they partner with us to do the workshop in their department. They allow us to do it at no cost, to use their space at no cost. But that requires a little bit more work on our end to, get in there with the departments and get them to agree to host it. Whereas if we just host it somewhere on campus in our student center, we pay the fee and we've got the space. So it's sort of a balancing act. Also, we don't have a set plan yet for how we're going to sustain some of the trainings that need recertification. 11 of us in a couple of years are going to have to get recertified as QPR, or if folks leave and new staff come, they're going to have to be newly trained. And our director is definitely prioritizing that type of money. When we get mental health monies that can be earmarked for programming and outreach, that those are the types of things that would go to first. because once everyone's trained, it really can keep rolling on its own. And then the evaluation piece is really important. Prior to the RAND evaluation process, the counseling center, like a lot of counseling centers did, we had our own evaluation forms that we would give out at our outreaches. And it was pretty standard, and it primarily only measured quality. Did you like the workshop? Was the presenter prepared? Do you know more about the counseling center since you attended the workshop? And that was really all we were collecting at the point. It was like a one-pager. I think the RAND evaluation process made us realize how important it is for us as a center to get a lot better at measuring our reach and our penetration of our outreach. And so we've actually identified as a goal for this coming academic year for the outreach committee to enhance our evaluation process and shift to something that looks a little bit more like the RAND evaluation, that's actually measuring something pre and post, so we can start to say something a little bit more about, as a result of our outreach efforts, X, Y, or Z is shifting or happening on campus. That's going to help us first just for outcome quality measures, but also if we want to justify continued funding for some of the things that we're doing, we want to be able to demonstrate that they're having an impact on the campus. And also we are reestablishing in our counseling center a research committee that's going to really take this task on as their main initiative. And we're in the process of recruiting staff who specialize in things like that. So we're really making it a priority at our center to improve that part of our provision of services. Any questions?
In the step-up bystander training, does that include information on sexual assault prevention that teaches the SAVAC mandates?
No, so we have another bystander intervention program on our campus called Green Dot Training that focuses more on that piece, and our campus assault resources and education office, which partners with us on Step Up, does a version of it that integrates Green Dot with Step Up to cover that stuff, and they'll primarily take all those requests.
What focus does your Step Up program take then?
Our Step Up program takes a really broad focus. We got some feedback from students early on who went through the Step Up training that the things that they experience the most on campus are microaggressions and discrimination. So we integrated that. Step Up gives you a lot of opportunities, examples, and vignettes and role plays. So we made up some of our own role plays based on student feedback. But we do focus on mental health, substance abuse. We focus on just general issues of stress that may not be directly related to mental health, like more academic. So we try to keep it really broad.
Do you share that?
Yes. Yeah. We can share our version, but also there's a Step Up website. I can go back to the site. Everything Step Up related is free to download to the public. Step Up is free for everyone to use, and you don't need a specialized certification or training to train for Step Up. You just need to go through it with someone.